All right, welcome back, everybody. It's my pleasure to introduce Dr. Edward Margolin. He completed a residency in ophthalmology at McGill, and then he completed a neuro-ophthalmology fellowship at the University of Michigan under the supervision of Dr. Jonathan Trobe and Wayne Kornblath. Currently, he's a full professor at the Department of Ophthalmology and Visual Sciences and Department of Neurology at the University of Toronto Faculty of Medicine. He's also director of neuro-ophthalmology and adults through business fellowship at the University of Toronto. Since coming to Toronto in 2007, Dr. Margolin has established a very active clinical practice in comprehensive ophthalmology and neuro-ophthalmology. After 5 years of full-time practice at Mount Sinai Hospital, Dr. Margolin moved to Toronto. He performs cataract surgery at Kensington Eye Institute and adults for business surgery at Mount Sinai Hospital. Dr. Margolin is on staff at Mount Sinai Hospital and Toronto Western Hospital. He's been teaching ophthalmology and neurology trainees at all levels, as well as participating in a variety of neuro-ophthalmology educational programs for the Department of Internal Medicine, Emergency Medicine, and Family Medicine. In 2011, then again in 2015, Dr. Margolin was awarded the Best Teacher in Ophthalmology Award. And in 2013 and in 2021, he was nominated and awarded the Whiteman Barris Academy Individual Teaching Performance Award. In 2017, Dr. Margolin received the J.S. Crawford Teaching Award, which was the most popular teacher. And then in 2018, he was a recipient of the Professional Association of Residents of Ontario Excellence in Clinical Teaching Award, awarded to 2 physicians at the University of Toronto yearly. In 2021, he was awarded the Distinguished Educator Award at Mount Sinai Hospital. Well done. Dr. Margolin has published over 200 peer-reviewed articles and given multiple lectures nationally and internationally. He's been actively involved in the North American Neuro-Ophthalmology Society, where he sits on several committees. His research endeavors are focused on understanding the mechanisms and looking for treatment for non-arteritic anterior ischemic optic neuropathy and understanding the pathophysiology and best treatment practices for patients with idiopathic intracranial hypertension. He's a clinical lead at the Kensington Eye Institute in a large multi-center collaborative research project investigating the relationship between the quantitative levels of beta amyloid protein and crystalline lens and development of Alzheimer's disease. So please welcome Dr. Margolin today. I guess he had many choices to what to speak on today, but he chose optic neuritis. When is an emergency? Welcome.
Thank you. Thank you for the generous introduction. Thank you. It's an honor to be here and to hear your wonderful presentations and to get a little glimpse of all the residents, all this wonderful residents in your program. It is really kind of late on a Friday afternoon, and you've already heard a lot of really heavy-duty science lectures. So I'll try to keep you entertained and awake. It's not going to be too long, I promise. And I'll just start with a little preamble. It took me a while to decide what topic to pick today. And I thought maybe I should present you a few fascinomas, like we've done a little bit already. Then I changed my mind and I thought maybe I'll show you some unusual manifestations or more common diseases. Then I thought maybe I'll highlight something new in neuro-ophthalmology. And then I thought that I really need to decide what should be the main goal of my talk today. And then I thought back to my own teaching triumphs and how I achieved them. And I realized that the main purpose of any clinical teaching, in addition to imparting knowledge, really should be to inspire others, even when these other people don't share your passion for the subject matter. So today I'll try to inspire you, even if you don't have any interest in neuro-ophthalmology whatsoever. And I'll try to inspire you by sharing our own journey. And when I say our, I mean all of my collaborators, the medical students, the residents, the fellows, our other neuro-ophthalmologists at U of T that I work with. So our journey of discovering intricacies of one particular disease. And I'm hopeful then hearing about our journey, you will be inspired to reflect on your clinical practice and think of one or maybe even a few projects that you can embark on. They will not only deepen your knowledge, but create new knowledge. And in the process, you will reignite your passion and create this excitement and engagement with your colleagues and other trainees. It is with the common goal of creating this new knowledge that we can benefit others and we can keep ourselves excited about what we do day in and day out, which can be sometimes difficult. So I'll take you through our journey of discovering little intricacies about this one particular condition that you'll hear about, MOG-associated optic neuritis. This journey started around 2017 when we first started learning about this condition and when the testing for it became available. Our beginning was very humble. All we did, we simply labeled all patients that we saw was MOG and entered them into our database. Then once we reached a critical number, once we got 30 patients, we decided to summarize the clinical presentation of that small cohort, and then we published our results. And then once we've done that, we've noticed something a little bit peculiar. As you know, most patients with MOG will fare well vision-wise, but some of them will not. So that led to further digging and searching to try to figure out what is it that influences the final visual outcome in this disease. And that is a story that I'll share with you today that I'm hoping will inspire you to do something that you, in your own specialty, something that will lead you to your own journey to discovery. I was showing you this picture, and it shows three animals that kind of look alike. And you might think that maybe they belong in very similar species, but in fact, one of these pictures is showing a deer, and the other two pictures are showing two rare species of African antelopes. One is an Eala, and the other one is a Sternbach. So they're very different animals, but one of them is a deer. And the thing about deer is that it is actually an animal that lives in all countries, on all continents. It is a ubiquitous animal. It found a way to adapt to all conditions. So why did I choose this picture to show you? Well, how is it relevant to optic neuritis? And the reason I showed it to you is because the entire journey is based on trying to figure out who is a deer and who is an African antelope. So who is a deer? Deer is our prototypical optic neuritis. And I wanted to show you that picture because you can use it to build your memory palace, because this is how a patient with a typical optic neuritis will look like. It is usually a Caucasian woman who is in her second or third decade of life, who has a little bit of pain, or maybe a little bit more than a little bit on eye movement, or pain around the eye. So that is a patient with a typical optic neuritis. So again, 70 to 80% will be Caucasian women. Their age is 20 to 40. The vision is better than counting fingers in vast majority of patients. And actually most will have vision between 20/40 and 20/200. Vast majority will have some amount of pain. Usually it's a pain around the eye, and sometimes this pain is worked with eye movement. Not always, but sometimes it is only present with eye movements. And in vast majority of patients, the optic nerve will look normal or somewhat normal, or maybe just a little bit elevated, but sort of in the variety of that, either normal or slightly elevated, but nothing out of ordinary. The vision, as you know, will return to baseline in almost all patients with optic neuritis. Now, the color vision and the contrast sometimes will not, but the central acuity should. The steroids, as we've learned from optic neuritis treatment trial, and as all of you know, they speed up the vision recovery, but they really do not do anything else for this disease. So it is optional whether or not to treat this patient with steroids. Now, in around 2015, we started learning more and more about two separate entities, which I term antibody-mediated optic neuritis, because both of them are precipitated by the presence of particular antibodies. And so these entities, these are two species of African antelopes. They're certainly not deers. The first one is NMO, aquaporin 4-related antibody-mediated optic neuritis. It's actually quite intriguing to hear about aquaporin 4 channels in the talk earlier today. That is ubiquitous channel present in the central nervous system. And the second entities are MOG-associated optic neuritis. I will only talk very briefly about NMO and focus the rest of the talk on MOG-related optic neuritis. So what are the phenotypical features of atypical optic neuritis? Now, this is a slide that I came up with myself. You might disagree with some of the criteria that I've chosen, but it kind of work most of the time. So what I consider atypical, so anybody who's over the age of 50, anybody who's not Caucasian. Now, of course, if you're in a certain part of the world, majority of you patients with typical optic neuritis will not be Caucasian. But again, for my practice, I consider anybody who's not Caucasian to be in an atypical category, and I evaluate them further. Anybody who has poor vision, that's really important. Anybody who has vision of 20/200 or worse, I would consider those patients atypical. And those patients have no pain at all or very severe pain. That will also be atypical. Obviously, the ones who have bilateral disease at presentations, and patients who have moderate to severe optic disc swelling. And again, arbitrarily, I chose that number, over 150 microns in peripapillary RNFL. And if they have any peripapillary hemorrhages, these are distinctly uncommon in typical optic neuritis. So if they have even one peripapillary hemorrhage, I'll consider it atypical. And then imaging-wise, you're all familiar with these definition of they have longitudinally extensive enhancement or predominantly optic nerve sheath enhancement, like in the case we just heard of immune point inhibitors mediated optic neuritis. Whatever likes to affect the sheath is usually not a typical MS-related optic neuritis. And the last slide is the last point is important. Patients have very quick response to steroids, meaning in 2 days, their visual deficit is gone. That is atypical. Usually takes weeks rather than days to get better for patients with MS-related optic neuritis. Patients who recur after the steroids have been tapered, patients who show no response to steroids, and those who have poor visual recovery. So that is my checklist of what are the atypical features. Now, let's talk very briefly about neuromyelitis optica. And again, I'm not presenting to you stuff that you don't know. You all know that, but we're just reviewing it for a short amount of time. So what is happening in NMO? First, what needs to happen is the B cell that is circulating in the peripheral blood that was already primed a little bit against the aquaphor and port channel will be stimulated to become really active against that particular receptor by T cells. The T cell has to be involved. And then as a result, you get an active plasma cell, and that active plasma cell, again, with the help of effector T cells, will then penetrate the blood-brain barrier and enter the central nervous system, where it will have its deleterious effect. So what happens in the CNS once these antibodies enter it? The antibodies bind the aquaporin 4 channel, which is ubiquitous in the central nervous system, but there is a particularly high density of these receptors on the surface of the astrocytes. And NMO is really an astrocytopathy. This is disease directed against the astrocytes. Astrocytes play a crucial role in the central nervous system. They help with preserving the myelin. They also help with preserving the integrity of the tissues. And the entire pathological process in NMO is directed against the astrocyte. So once the antibody binds the aquaporin 4 receptor on the surface of the astrocytes, the immunological reaction will continue, the macrophages will be recruited, various cytokines will be released, and the end result is the death of the astrocyte, which is an irreversible process. So phenotypically, NMO is, first of all, it's quite rare, and is a predominantly disease of non-white people. It does happen in whites, but much more common in non-whites. It is almost exclusively occurs in women. You will see some men with that, but it's very, very uncommon. They have poor vision and presentation. They have poor response to steroids. They have very long segment, typically of optic nerve enhancement, which is typically posterior. And usually it's not difficult to recognize that this patient has an atypical optic neuritis. And if we suspect NMO, we have to escalate the treatment very, very quickly to plasma exchange with the goal of removing these offending antibodies in order to preserve astrocytes and prevent their death. These patients have to stay on steroids for a long time. After they are started on treatment, the initial treatment is usually CTA20 inhibitors. There's now a range of C5 complement inhibitors also available. They're also used, and then these used interchangeably to see if the patients respond to one or the other. But this is a disease that requires treatment in all patients. And as I mentioned, usually it's not difficult to distinguish NMO-related optic neuritis from typical optic neuritis. And as I mentioned, this is really an astrocytopathy, immunological reaction that is really aimed against these cells, astrocytes. And the end result is the death of the astrocytes. They do not regenerate. Therefore, if we don't remove the offending antibody quickly, the astrocyte death ensues and there is no recovery. Now, MOG is a very different species. So what happens in MOG? Again, there is a peripheral B cell that is already primed a little bit against MOG that are circulating in the peripheral blood. Then for reasons that we don't poorly understood, sometimes molecular mimicry has been suggested because we know that MOG happens quite commonly after a viral illness. So this, in the peripheral blood, the B cell is primed with the help of a T cell, with the follicular T cells, which leads to the formation of this differentiated plasma cell. And the plasma cell, with the help of the T cell, again, enters the blood-brain barrier, breaks the blood-brain barrier, enters the central nervous system. And that complex, MOG antibody, will bind the MOG receptors, which are present on the surface of the oligodendrocytes. Now, oligodendrocytes are these supporting cells that are very important for producing myelin in the central nervous system. And once this binding occurs, that leads to further breakdown of the blood-brain barrier, more entrance of more of these cells from the periphery into the CNS, leads to the recruitment of various immunological cells, release of various cytokines, and the end result is the injury to the oligodendrocytes. Now, the oligodendrocytes, there's a lot of oligodendrocytes, and they can regenerate and they can continue to produce myelin after their attack. There are 4 patients with MOG often spontaneously recover, okay, which is almost never seen in NMO. Okay, so phenotypically, what's MOG-associated optic neuritis looks like. It is much more common than NMO. There is a slight female preponderance, but very slight. Usually, it's about 60% female to 40% male. It is equal in all races, so it does not discriminate. It occurs in all races. And if you look at the presence of MOG antibodies in all patients with optic neuritis, approximately 3 to 5% of patients with optic neuritis will have this antibody present. So it's not, it is rare, but it's not super rare. Typical age is about 40, but it can affect very young or very old. They usually have poor vision at presentation. Usually it's about counting fingers. They usually have pain. Periorbital pain is a really critical feature of MOG, which is present in many patients. And most of them, about 80%, will present with a swollen optic nerve. They usually respond to steroids very, very quickly, within days. And then about half of them will have a monophasic illness, while 50% obviously will recur. So that's the typical phenotypical profile of MOG. MOG is a different disease pathologically as well as phenotypically. So if you look pathologically at the lesions, most of the lesions in MOG will consist of CD4 positive T cells as opposed to MS, where lesions are composed most prominently of CD8 positive T cells. So it is truly a different disease. And again, I already told you that, but to emphasize it again, what's the phenotype of MOG? Only slight female preponderance, equal in all races. Usually vision is count finger in presentation, bilateral in 40%, so in a pretty high percentage of cases, swollen optic nerve with hemorrhages. And remember, hemorrhages are uniquely, distinctly uncommon in typical optic neuritis. Interestingly, if you look at children who have optic neuritis, 80% of them will have MOG antibodies circulating. So majority of children with optic neuritis will be MOG positive. And usually it presents on the contact of ADEM, acute demyelinating encephalomyelitis. Most of the children will have a monophasic illness, fortunately. So that is a very good thing. And as we already mentioned, 2 to 5% of adults with demyelinating episode will have MOG antibodies circulating. And in the optic neuritis treatment trial, The investigators had access to 177 serum samples out of a total of 450-something patients that were enrolled, and 2% of these patients had MOG antibodies circulating, as was shown in multiple other cohorts. And as I said before, half of the adult will have a monophasic illness. So what do we see on imaging in MOG? Again, this enhancement of the orbital portion of the optic nerve is the most common finding. It can be longitudinally extensive. It not always is. It can involve prechiasmatic optic nerve, and it can involve the chiasm. An enhancement of the perineural sheath is very common in MOG. It likes to affect the sheath and sometimes spare the actual nerve. And the treatment for MOG is high dose of corticosteroids. It always has to be initiated. It's a first-line treatment. And as opposed to NMO, when we escalate the treatment, we go to IVIG rather to plasma exchange in MOG. These patients always require a slow oral taper, typically around 4 to 6 months. And if they have full vision recovery, now when we talk about visual recovery, we're talking about both central acuity and perimetry. So it cannot be just one or the other. So if they have full vision recovery based on central vision and formal perimetry, no further treatment is usually necessary, and we just follow them. If they have incomplete recovery, though, we proceed to long-term immunosuppression. Azathioprine is usually our drug of choice, and plus minus monthly intravenous IVIG infusions. Now, back to our journey. How do we learn all that information about MOG? Most information that we learn derived from large clinical cohorts. So we decided after we've learned about this disease and we started collecting these patients in our database that we can characterize our cohort, which resulted in our first publication about this condition. We had 30 patients, but 46 eyes, and the data that we found was very similar to the data that I presented to you, that we had some female preponderance, the vision was about counting fingers, vast majority had a swollen nerve, and most of them did well. However, I told you already that most patients with MOG have excellent visual prognosis, but we had this one case that really puzzled us. We saw this woman who, this was during the height of COVID, and she noticed poor vision in one eye and then the other eye, and she was very afraid to go see anyone until she really, really couldn't see very well. She was working as a cashier in the supermarket, and she really found it hard to count cash already. So then she ventured enough courage to go to see her optometrist, and her vision was 2200 and no light perception. And the eye with the 2200 vision had a completely constricted visual field. So she waited for about 2 months to be seen, and we recognized this disease pretty quickly, and we started her in treatment, treated her very aggressively. Unfortunately, the NLPI never improved the eye with the 2200 vision. The central acuity improved to 20/20, but her visual field has remained very, very constricted. So that led us thinking that not really everybody with MOG does well, that some people do poorly. And then we had further observation. This was already when Dr. Broussard was working with us. We noticed we had a couple of patients that we saw that were treated immediately, right, almost within a couple of days of the onset of symptoms, and we treated them quickly and very aggressively. And they, unfortunately, though, ended up with a poor visual outcome. So we decided to relook at our cohort of patients, which at that point has grew to about 50. And we wanted to see how many of those patients who were started on steroids quickly, soon after the start of their symptoms, how many of those had poor visual outcome, and we found that 2 of them did. So not a big number, but a significant one. So they were both seen within 7 days of symptoms onset, both treated very quickly with escalated treatment to Plex and IVIG, and unfortunately, they improved very little. So here we got the data that although the visual outcome is reported to be quite good in MOG, it is not so in everybody. So then we started thinking about what is it really that predicts who does well and who does poorly. And now we have looked again at our large cohort, and this resulted in the publication in Ophthalmology, which is quite recent, and we re-looked at the same cohort with a different question. Now, the question was, what makes a difference? First of all, we wanted to see how many patients with MOG have poor visual outcome. That was our primary outcome. Now, we define poor visual outcome as vision of 20/200 or worse, or mean deviation of -5 or worse on perimetry. And interestingly, when we looked at all the previous papers published on MOG, when the investigators decided to describe visual outcome, they all used central acuity only, despite the fact that this disease likes to affect the optic nerve sheath and oftentimes will spare the central axon. So there was really almost no papers that described the perimetric data. So that was our contribution. We wanted to include that in the definition of poor visual outcome. And that stemmed from the observation that we had a few patients whose central vision was 20/20, but their fields were severely constricted as those of the patients with end-stage glaucoma. So clearly these patients are severely visually impaired. You can't call it a good visual outcome. That was our primary outcome. And a secondary outcome, we wanted to try to define what predicts this poor visual outcome. So first we'll look, does the time from the symptoms onset to the initiation of treatment matter? Then we wanted to see, does it matter which treatment we used? And then we wanted to see, do the imaging findings make any difference? Do they predict who will do poorly? So we had 45 patients, 65 eyes, and we found, to our complete surprise, that 42% of patients had poor visual outcome if you include perimetric data. So that was very different than was previously reported in literature. And the key thing that we found, that patients who had poor visual outcome waited for 32 days before getting treatment, as opposed to patients with good visual outcome who had an average time from symptoms onset to initiation of treatment of only 6 days. So that was our main and also quite surprising result. We found that oral steroids are non-inferior to IV steroids. And therefore, I mean, I wanted to wait until now to comment because you've discussed using IV steroids in several cases where patients were admitted. So we can really skip this whole admission process, which is cumbersome, expensive, difficult for the patients, and we give them oral steroids that can take at home. And most of them do quite well. So in it, we showed that it really makes no difference. And approximately half of our cohort were treated with oral steroids and half were treated with IV steroids. There was no difference in their outcome. And we weren't able to show any difference based on multiple radiological factors in their visual outcome. So to condense this entire talk into one slide, it's here. If you see somebody who has even one atypical feature, time to treatment equals their vision. So that's when optic neuritis is an emergency. And this is an attitude that we're trying to change in an ophthalmological community that previously, when we learned about typical optic neuritis, we learned that given steroids or not given steroids does not matter. It is very different for atypical optic neuritis, where given steroids is essential. If they don't get the steroids and if they don't get them quickly, it really makes a big difference. Each day matters. So if you see somebody who you think might have optic neuritis, they need to be treated aggressively and immediately. So that's what I just said. You need to treat them all aggressively, you need to follow them closely, and you need to escalate the treatment early. An escalation of treatment depends on whether you're suspecting MOG and NMO to either plasma exchange or IVIG, but one of these. So while we're awaiting antibody titers, and I don't know what it's like in Rochester, for us it takes 2 weeks to get the antibodies. About the same. We can't really get them any quicker than that. So that 2 weeks period can be critical. So we can't just sit and wait to see how these patients do. We usually see them in about a week. If they're not any better, we escalate the treatment to plasma exchange usually. So the other question that kind of always comes up is, because it does make a difference whether somebody has these antibodies or not, should everybody be tested for MOG and NMO? And the literature is very clear, and that's what we follow, is that not everybody needs to be tested. Why do we not test everybody? Well, number one, it's obviously expensive. And number two, there's a fairly high incidence of false positive, especially for MOG, which can then skew the treatment and skew everything. So that's why testing patients with purely typical optic neuritis is unnecessary. So if, in our practice, if patients have none of the atypical features that I showed, we do not test them. So back to our journey. Remember, my goal was not really to show you only the nitty-gritty of MOG, because many of you will really not deal with MOG, always refer patients with MOG, and really don't care too much about MOG. But I wanted to share with you our journey. Like, what did we do as a small little group? How do we contribute to the knowledge? So we're still thinking about the disease and still sort of mining our data. This is our latest. We wanted to really relook at the radiological predictor of visual outcome in this disease with here in this paper, which is currently in the works. It is in the journal. We have combined our data with the data from the Mayo Clinic. And now we have 129 eyes of 92 patients. And we found, very interestingly, that the less enhancement you have of the optic nerve, the worse you will do, particularly when you look at the optic canal. That is a bit counterintuitive, but we presume this is due to the fact that if there's a lot of enhancement, steroids will be quite effective. And there's very little enhancement, it's unlikely that the steroids will be effective. And there's a multitude of other theories that we put forward. But that's, again, something that came out with our very humble beginnings, just labeling patients, collecting the data, and then thinking what we can do with that data to create new knowledge. And then this is another thing that we're working on right now. We wanted to see how many patients with MOG had at least one atypical feature. Surprisingly, this hasn't been looked at in the literature. And our prediction that it will be all of them will have at least one atypical feature. And that will, again, help us decide whether it should be testing everybody or just those who have at least one atypical feature. So conclusions, we're almost done. Number one, obviously optic neuritis, patients who have any atypical features that I showed you, or if you don't remember the atypical features, just remember something very simply. Optic neuritis patient with poor vision, treat them aggressively right away, follow them closely, and do not hesitate, escalate your treatment to the next stage. That's conclusion number one. And conclusion number two is think about your own journey and what you can do to contribute to this, our whole state of knowledge, what new knowledge you can produce. Thank you for having me.
In the past, people would be treated with oral steroids who were suspected of having multiple sclerosis. And that was changed, and they were because of increased recurrences.
Right.
There was then started on IV steroids.
Right.
Now, how does that fall into your comment about oral steroids being as good as IV steroids?
Okay, excellent question. So oral steroids that were used in optic neuritis treatment trial were low-dose oral steroids. They use 60 milligram, well, one milligram per kilogram. So it comes out to be around 50 to 60 milligram per day. And those apparently, I mean, the analogy that is commonly used is like tickling a bear. They do a little bit, but not enough. So you want to give a lot of steroids. You want to really suppress the immune response. So high-dose oral steroids are bioequivalent to 1 gram of Selamedrol, which was used in an optic neuritis treatment trial. So it's the same thing. So we're just merely changing the route of administration, but the dose remains the same. Excellent question, though.
So if you're seeing someone who has typical features, but may perhaps also have MOG, if you treat both of them with high-dose oral steroids, then you have the same outcome, basically.
Correct. I mean, the only thing is that I'll say if they only have typical features, it's very unlikely they have MOG. Pretty much everybody has at least one atypical feature that we went through. Remember, MOG, 80% will have really significantly swollen optic nerves. Bilateral in 40% of patients, they'll have significant pain. They'll have, even if you start them in treatment, patient with MOG will respond very quickly. Like this Monday, we saw a patient who I strongly suspected has MOG, and she presented with a light perception vision. And her whole story started with pain around the eye. She had a lot of pain, went to see an optometrist, the exam was normal. And then 2 days later, she went to emergency vision with light perception. And we started her on treatment. I thought she had MOG, and then she called us 2 days later, her vision was back to 20/20. So even before getting the antibodies back, we know that this is almost 100% going to be MOG, not an MS-associated optic neuritis. Yes.
I wanted to ask, in terms of the like radiologic findings, has your group done any work with respect to like spinal imaging, that kind of extended thoracic findings they sometimes find?
So that's an excellent question. Most patients with MOG, vast majority of them will not have any abnormalities in the spinal cord, and most of them will not have any white matter lesions. So that's another thing. That if you see somebody with an optic neuritis and their MRI only shows a little bit of enhancement of the nerve, but no white matter lesion, that's something that will kind of sway you a little bit more in the direction of the antibody-mediated optic neuritis. So MOG very rarely affects the spinal cord. It does happen, but it is distinctly uncommon.
You talked about azathioprine as a long-term immunosuppressive medication for these patients. Given that
For MOG, not for NMO.
okay.
Yeah.
Given that this is antibody-mediated, what about rituximab or any of the?
Well, that's a good question, but we're getting like really in the nitty-gritty. So, so rituximab, interestingly, is not very effective against MOG. Only about 20 to 30% of patients respond to Ritux because it's a CD20 inhibitor, which does play a role in its overall immunological cascade that I showed you. But rituximab seems not to be super effective in MOG. And azathioprine is our kind of sort of drug of choice. But what I'm kind of believe more and more strongly is that IVIG is probably the most effective treatment. So we treat these patients with high doses of IVIGs, like 2 grams per kilograms once a month for a long time. The ones who recur have poor recovery.
With the outpatient treatment of the high dose steroids, is there a PCP following along to track sugar?
That's such a good question. It's an amazing question because really this oral steroids kind of change everything, right? Because you don't really need much help. You can treat these patients right in front of you. And we don't really, because we really give them 5 days of 1250 milligrams of oral prednisone. You can give 3 days. It probably is the same thing. And that really does the trick. We usually warn the patient. We usually give them a PPI to protect the stomach. We warn them the most common side effect of high doses of steroids will be various psychiatric side effects, usually the anxiety, difficulty sleeping, kind of jumpiness, irritability. We try to protect their stomach with PPIs, and really vast majority of patients do very well. And we do this, every day we prescribe it to somebody, literally. Can't think of a day when we didn't give it to someone. And most vast majority of patients do well. I mean, we did have one person who developed psychiatric side effects that required admission. That's it. But most of the time you can do it very safely. I don't know, Zoe, has been your, I don't know, do you guys use this oral steroids?
I have done that extremely rarely just because of worry. I think it's in the patients with MOG, it might be a better demographic, or with typical demyelinating optic neuritis because they're younger, but I have not really embraced that for older patients because I just think you are going to have more comorbidities and it's harder to know what's going on if they're at home. So, I know it was equivalent in the French study, and I don't argue with the science, but I just think as far as comorbidities,
you just feel it's safer for them to be monitored in the hospital.
In-house. I've had one patient with hepatitis from high dose oral steroids. So I think once you have experienced it, you might be less likely to want to do it.
Well, here you heard Dr. Williams' view on that. But we do it all the time. Not just for optic neuritis, we use it for various types of inflammatory disease. Like we saw somebody this week with an orbital apex syndrome that is, not yet diagnosed, and we use it for that patient, and responded very, very quickly. I mean, you have to swallow a lot of pills, but logistically, it's just so much easier. You don't have to go through like 3,000 hoops and admit them and stuff like that. Any other question?
Do you routinely follow the MOG titers to see if you can predict if it's monophasic?
Yeah, so that was such an excellent question. I had this question myself. These patients, the ones who have really done poorly, the ones who do well, no, I don't. The one who did poorly, I do. Like I recheck their titers once a year. I don't know exactly why I do that, because we know that an animal for sure, the ones who convert to from positivity to negativity tend to do well. And when they convert back to seropositivity, that's a predictor of another attack coming. But it's different in MOG. Patients in MOG can have long-term positive antibodies. The literature is very conflicted on that. And we even know that in patients with MOG, they can have very long-standing, sometimes lifelong, mild enhancement of the optic nerve. So we don't really jump and think that this is a recurrence, because we know that that is something that we will see. So, but again, so in those who recover completely, I don't. And those who have incomplete recovery and you're worried about another recurrence, I do order titers. What would I do differently? I'll probably make sure that they continue getting their IVIG 2 grams every month, et cetera. I actually had to do that to make the decision this week. So somebody was like, what to do with him? It's been about a year. He's not really any better, but not any worse. What do we do? So we decided to reimage him and reorder the titers. They were still positive, and then we put an order for IVIG to continue. Any other questions? Thank you, guys.
Thank you.